Post-SSRI sexual dysfunction PSSD in women versus men. Okay, in this video I want to show the differences between the treatment of PSSD in men and women. Okay, so honestly, PSSD shows overlapping core neurobiological features, okay, both in men and women, but also has important sex-specific differences, okay, and these are driven by hormonal, neuroendocrine, and receptors level distinctions, okay. So let's talk about structured breakdown, okay. So the core PSSD symptoms, both men and women, okay, so things like sensory symptoms like genital numbness, loss of erogenous sensation, reduced pleasure during stimulation, okay, loss of spontaneous sexual thoughts, decreased desire, emotional blunting, okay, so anorgasmia, reduced satisfaction, blunted orgasm, anhedonia, okay, so reduced lubrication or erectile response, okay, impaired genital blood flow. It is the same for women and guys, okay, so also there are cognitive things like brain fog and reduced revert sensitivity, okay, so the one thing is pretty much common, okay, so mitochondrial and energy, okay, because fatigue, low motivation, exercise intolerance, insomnia, all these kind of things are really the biggest issue of SSRIs, because SSRIs are doing or having bad effect on mitochondrial health. So this one thing is pretty common. Okay, so yeah, core mechanism that are causing these persistent changes in 5-HT1A autoreceptors, okay, and this is affecting dopamine signaling, okay. There is also reduced sexual reward sensitivity, okay, because of that. Parasympathetic suppression, okay, so reduced nitric oxide. Nitric oxide is reduced in both men and women, okay, so not only like for men, like for erection, okay, so also there are blunted oxytocin and neurosteroids, okay, pathways because of that. And like I already told you, okay, so it's mitochondrial dysfunction. Honestly, from my experience, treatment for guys is much more complex, and I think it's easier to fix women than a man, okay, because the man most likely has also effect from androgens itself, and we have also androgen receptors and so on, okay. So female PSSD and predominant features are like from neurochemical aspect, it's more like oxytocin dopamine dysregulation, okay. Of course there is 5-HT1A receptor desensitization that can also have effect on oxytocin in women, but with less androgen involvement, okay, as in men. Probably almost no androgen involvement, okay. So women generally maintain stable estrogen testosterone ratio post SSRIs, okay. So in guys androgens matter, okay, but it's not that obvious like in guys, okay. So symptoms, there are things like low libido, genital numbness, loss of lubrication, anorgasmia, inability to feel emotional connection. This is because of the oxytocin blunting, okay. So labs are frequently normal, okay, despite severe symptoms, okay. So treatment response, treatment is really should be focused from my point of view on oxytocin and dopamine, okay. So you can use dopamine agonist for short time, but it's not a solution. Solution is like for both men and women mitochondrial fix, because for example, if your mitochondria are working really good, okay, you need to understand that also your neurosteroid will be produced, because for everything you need energy, okay. So So as for women, I would say dopamine agonist, like making D2 receptors more sensitive, okay, oxytocin enhancers, HDAC inhibitors will work very well. And like I said, the fix can be in shorter time compared to men, okay? So of course, we have a clitoric or clitoral blood flow reduction, okay? This is because of the serotonin. The same apply for guy, okay? So, but this is for erection and this is for clitoris, okay? So you really need to understand that you can do the same, okay? You need to improve your nitric oxide synthase. And the last thing is like mitochondrial aspect, okay? So low energy and fatigue, okay? So this can be fixed also like in 3 to 6 months, okay? So because depends how long you took SSRIs and so on, okay? So in male, it's like I said, it's really different. For men, I would immediately check estradiol, prolactin, okay? Because in most cases, prolactin is elevated or was elevating during that time. Prolactin, you need to understand, it blocks like testosterone and DHT production, especially conversion from testosterone to DHT, okay? Okay, so for men, you need like multi-targeted strategy, okay, like dopamine, androgens, vascular and androgen receptors support, okay? So things like bupropion will not fix anything because it would be only one part of solution, okay? So yeah, erectile dysfunction, it's also, like I said, mostly because of, in many guys, elevated prolactin, estradiol, okay? So, and for example, for some guys you also need penile rehab, because if you have not gained nocturnal or morning wood erection, so your penile tissue was affected, okay, and you need to improve it, okay? This takes time, okay, guys. This can take from 3 months if you have not been having erection for a short time, up to like 12 months, okay? So there are different strategies. If you need my help, you will find the email under this video, okay? Also, parasympathetic tone, okay, is impaired, okay? So, and because of the low DHT, your penile tissue is impaired, nitric oxide, even NNOS, something that is like triggering erection, okay? So mitochondrial dysfunction is the same as in women, plus low NADPH need to be fixed for 5-alpha reductase. For mitochondrial dysfunction, you need to be more careful because women, they don't need to think a lot about NADPH, but in men, there should be balance because of the mitochondrial boost and NADPH, okay? Because NADPH also need to be managed for proper 5-alpha reductase function, okay? So yeah, epigenetic remodeling can be applied for both genders. Okay, so that's it. Let me tell what you think. Like I said, to fix PSSD in women will be easier, but also for men it's also possible, but it takes some time. It's not overnight success story.